Thank you, sir. I acknowledge my co-authors and have no financial interests. So I'm going to report a novel finding of epiretinal neovascularization in MACTEL and describe its clinical and multimodal imaging features. So we know MACTEL2 is a neurodegenerative disorder. There are various staging systems in place: clinical, OCT, autofluorescence, FFA, and ICG. OCTA has recently given us insights about the deeper capillary plexus as well. So I conducted a retrospective chart review in diagnosed patients of MACTEL type 2 who came to our clinic from 2nd Jan 2017 to April 2018. We did the clinical and the multimodal examination in all of these patients using the Heidelberg platform. We did the OCT with a 20 degrees angle, and the distance between the two scans was 30 microns, and an ERNM or an ERN was described as a thin membrane on the SBOCT. So an OCTA was also obtained in all these patients in a 3x3 scan, and the distance was only 11 microns between each scan, and a vascular membrane at the vitreoretinal interface was described as an epiretinal neovascular membrane. In addition, we also saw a hyperreflective structure or a flow signal which suggested intraretinal communications. So we saw 68 eyes of 34 patients of MACTEL in total, of which we saw that 7 eyes of 4 patients were identified to have an ERNM, of which we had 2 females and 2 males with a mean age of 56 years. Of these patients, only 1 patient was diabetic. So this is the first case. She's a 48-year-old female with diminished vision for near. She's a diabetic since 3 years. She had 6/9 and N8 vision in both eyes. You can see that there is this typical macular telangiectasia pigment and background diabetic retinopathy in this patient. So there was this lumpy membrane atop this intraretinal pigment in the right eye, and the FFA showed the typical MACTEL staining in the late frames. We did a wide angle FFA to rule out any extensive capillary non-perfusion or other PDR features. So this is the right eye OCTA, where we were surprised to see this big vascular network where we delimited it to the VR interface. Next is the left eye. This is again the right eye. This is a hyperreflective structure that is shown as a vascular communication. This is the ICGA, where we didn't find any CNVM. Of course, it was blocked by pigment. This is the left eye, where we see again a very, very thin membrane. Left eye FFA, ICG. Coming to the OCTA, you can see again that there is a vascular structure which is best seen on the vitreoretinal interface. This is case 2. This is a unilateral ERNM. You can see this thick membrane on top of the retina. The other eye does not have this membrane. This is the diffuse FFA leakage. And when we see this membrane, it is actually seen also here because of a projection artifact. But when you delineate it, it is actually best seen on the VR interface. So this is case 3, which has bilateral MACTEL type 2 with bilateral asteroid hyalosis. This is the FAF with stage 3 FAF, and this is the FFA with the circumferential staining. So I actually have a video FFA of this patient where you see that the early frames show that there is early filling of this ERNM, and if we can bear in mind the shape of this filling of this network, which is in a sleeping Y position, if you just remember this shape, you can actually see it on the OCTA also in a Y shape, which is all the more reason why it is on the VR interface, because there is a tag that is actually extending into the vitreous. Case 4 is again bilateral pigment in a 60-year-old gentleman. This is the multicolor image of this patient. So this particular case had a very thin wispy membrane on top, which was again an ERNM. And if you see, this is the OCTA of this patient, which shows 2 segmented ERNMs corresponding to the fragmented ERNMs on the OCT as well. So this is the wispiest membrane in my series of patients. We have one paper, one report which came out in 2014 of one case of ERM with MACTEL. OCTA was not done in this case. In our cases, ERNM, like I call it, has a communication with an intraretinal hyperreflective structure, suggesting that maybe the retina is becoming too thin and leading to bearing of the abnormal capillaries of the superficial plexus itself on the retinal surface, or like CNVM, ERNM is a distinct endpoint of MACTEL associated neovascularization. There were some common features associated with all these ERNMs in this series. All of them had pigment. The CNVM also occurs after the stage of pigment, like we know in the clinical staging. We wonder if the superficially migrated pigment incites ERNM instead of a CNVM. Remarkably, in all my cases, there were no empty spaces, ILM drape sign, or a lamellar macular hole that is typical of MACTEL2. So differential diagnosis that comes to mind, especially in diabetic retinopathy setting, is a foveal neovascularization. But there was, in our series, there was only one diabetic patient and she didn't have PDR. Another differential is a lamellar hole epiretinal proliferation, considering MACTEL also has LMH, but I have imaged 2 cases of LHEP and it is not vascular. So ERNM does cause a projection artifact which is distinct from the dragged vascular complex of MACTEL. Should we consider it as a distinct end-stage neovascularization like SRNVM? Should we treat it with anti-VEGF? And it is easy to monitor response also because of OCTA. So to conclude, this is a novel entity. Small sample size is a limitation. We recommend that all epimacular membranes be multimodally imaged, and it may represent a hitherto unknown form of proliferative MACTEL like SRNVMs.